I think we'll go ahead and get started as we see more attendees joining. Good morning or afternoon, and welcome to everyone taking part in this webinar. My name is Camden Hoffman, Senior Social and Behavior Change Team Lead for Breakthrough Research with the Population Council. Breakthrough Research is USAID's global flagship social and behavior change research and evaluation project led by the Population Council with a consortium of partners. It is my pleasure this morning or afternoon to some of you to introduce our presenter from one of our consortium partners, Jana Smith, Managing Director of Ideas 42. Jana will present the findings from a breakthrough research pilot evaluation led by Ideas 42 that focused on provider provision of respectful maternity care that took place in Zambia in late 2019. This pilot focuses on testing of solutions developed through an iterative behavior design process based on the original findings from the formative research phase. The presentation will be recorded and the PowerPoint will be circulated to all participants after the webinar. Jana, I turn it over to you.
Great. Thanks very much, Camden, and welcome to everyone. We're excited to be together to share the findings from the work that we've done in Zambia on promoting respectful maternity care. I did want to mention that also on the line are my colleagues Ali Schachner from Ideas 42 and Dr. Amit Kamanga from our partner SM360. So when we get to the question and answer section at the end of the presentation, they may also be chiming in. So as Camden mentioned, this work was done under Breakthrough Research. And to outline what I'll be going through and sharing today, I'm going to talk a little bit about the project background, very briefly some of the formative research findings. I'll share the different solutions that were developed, the evaluation design. I'll highlight a couple of key takeaways from results from the perspective of impact. We'll touch on a few implementation learnings and then next steps, and hopefully have ample time for questions. Just a quick note that Ali will be looking through the chat feed, so feel free to put your questions in as they emerge. If they're clarifying questions, she will likely respond to them in the chat. And if they're more substantial questions, we may hold them for the Q&A, which I'm planning on leaving at least 20 minutes to be able to have some hopefully rich discussion in the online format. So in terms of project background, this work was done in collaboration with the USAID Safe Motherhood 360 project and the Chipata District Health Office in 4 phases over the course of a few years. So in a first phase, we were defining what was the provider behavior that we would be looking at as a project and identifying a partner who was interested in doing this work. We then conducted formative research. We led a co-creation process of solutions and then conducted a pilot and an evaluation of that pilot. I'll be touching on findings from these different phases today. So as Camden mentioned, the way we define the behavioral problem focus was that providers don't consistently follow best practices during delivery, especially those related to respectful maternity care. This was a problem that was of interest to our partner, SM360, was of interest to the ministry and specifically the Chipata District Health Office. And we definitely found evidence that this was a challenge in Zambia. So this crowd probably doesn't need a lot of convincing as to why respectful maternity care matters, but just to quickly highlight from an impact perspective why we thought it was important. Certainly there are human rights implications. A woman's right to have a delivery free of disrespect and abuse. The literature has established that there's certainly an impact, negative impact on health outcomes when women have these experiences, and it can also impact future care seeking for follow-up reproductive health services, maternal health services, child health services, etc. So I won't spend a lot of time diving into the formative research findings, but if you're interested in reading a more detailed write-up of what we found, I've included the link at the bottom of this slide. This is a peer-reviewed publication, but it's open source, BMC Pregnancy and Childbirth. So you can certainly read in more detail. But this formative research was primarily in-depth qualitative interviews with women in the postpartum period with providers in different facility types, with their supervisors, with other community members. We also conducted a good deal of observation within the delivery wards to highlight a couple of high-level insights, which will then flow into the solutions that we developed and the way we thought about the theory of change and the evaluation itself. We did find that harsh treatment was very normalized within the clinical setting, and that when providers did engage in disrespectful care, there really weren't consequences for doing so. Another insight is that providers were very focused on death avoidance over everything else, over all other elements that you could envision being important for quality of care. And this was very much reinforced from their clinical formative training to the kind of supervision that they would receive, to all the visual cues within the physical space in the facilities. A final insight to highlight is that the pain of labor and the implications of being in pain were very much part of the challenge. So certainly pain of labor will have a negative impact on a woman's experience in a very direct way. But we also found that as women were not supported during delivery, did not receive any kind of pain management from the provider, they were also less likely to feel trust and rapport and be able to, in some cases, follow instructions that were for the health of their baby and themselves. But more than anything, this quote unquote lack of cooperation, if we want to call it that, providers use as a justification for being harsh. So that was another insight from the formative work. So the next phase of work was a co-creation process that was together with SM360, with the district health office, with the providers in the facilities, supervisors, and certainly women in labor. This was an iterative process over a few weeks where we co-developed solutions, we iteratively developed and refined features, we dropped solutions, we added solutions. And the result of that process are these 5 final solutions, which you can see here. The first we dubbed the Better Pain Management Toolkit. And the objective of this solution was to really elevate the role of pain management in the mind of a provider as a critical component of routine clinical care. So rather than try to generate additional tasks, the idea that the providers needed to be engaging in ways very outside of their current priorities, we tried to take pain management and incorporate it into their current priorities and the way that they think about their role. So the manual itself is meant to some clinical manuals that they receive. We developed this mnemonic of better to try to make it easier for providers to remember the different techniques. We did some color association tests, so you'll see the color schematic across the materials displayed on this screen that were most intuitively associated with these different techniques. And the manual itself articulated how these different pain management techniques would be realized with simple illustrations, but also linking them to the clinical evidence around the impact on outcomes, which are the area of utmost priority to providers. You'll see on the right-hand side another tool, which is the partograph, the tool that's used by clinicians to monitor the progression of labor. Here we put reminder cues or suggestions for concretely when providers could be applying different techniques. Again, very much to try to embed the idea of pain management as part of routine clinical care. On the left-hand side poster, this poster was meant to be a reminder at the moment when a provider could be providing support to a patient by having the poster be at the bedside of the woman to be a very top-of-mind reminder when they were there with her. The poster is also intended to put in the minds of women these illustrations that show a provider providing support so that she could ideally start to have expectations around this kind of care. And for those that are illiterate, you can see at the bottom an actual call that women could ask providers for this kind of support. The final component of the toolkit are these massage balls, which are on the right side. They were certainly the technique and the tool that was most well received by women in labor, and also a visible and a sensory reminder to providers of pain management, given that they'd be sitting in their apron pockets. A second solution that we tested and refined and moved forward into implementation was the idea of the provider-client promise. This promise was meant to be an expectation-setting exercise between each provider and each patient upon admission to the labor ward. Given the unequal power dynamics in the relationship, this also intended to try to put both on equal footing in that they're each promising to an equal number of items, and they're talking about working together as a team to try to guarantee a safe delivery, which is an outcome which both of them want. A couple of other components to highlight here is that there's a promise on the provider side to explicitly not yell, scold, or slap at any point, to a promise to treat women well. The intention here is that by having the providers state out loud that they will not be engaging in this kind of behavior, the hope is to create a bit of dissonance and discomfort should the provider later in the delivery feel the urge to do so. And finally, there's a mention of pain management on both the provider and the client side, again, to try to reinforce what's in the toolkit in terms of pain management being an expectation and a critical part of what should be happening during the delivery. The third solution is the feedback box. This is a different take on what we could think of as a suggestion, and one that tries to tackle some of the insights that we generated in the formative research phase. So in this context, there were suggestion boxes, but they were located outside of the delivery ward. So it would really be a hassle for somebody to have to proactively seek them out rather than have it be something on their way out of the facility. A second component was that they would require a written suggestion or a written critique, which certainly limits the number of people who are able to engage. And generally what we know about suggestion boxes of that sort is that they attract the attention of people who are either very satisfied or very dissatisfied with their experience, rather than necessarily providing a more even-handed sense of how satisfied clients are. So the idea of this feedback box was, rather than have it be opt-in, to default women instead into providing feedback. So the feedback box was located upon exit from the labor ward to decrease the hassles involved in providing feedback. Each woman was given a wooden token. It was reusable upon discharge from the facility, and all she needed to do was to drop it in the slot that best represented how she felt about the experience. Should certainly note that this feedback box is not meant to be a comprehensive means of evaluating client satisfaction and identifying opportunities for improvement, given its limitations, but instead to have it be a bit of a pulse check for each facility to see how clients generally seem to be feeling, try to elevate in the minds of a client the importance of her voice, and there is interest on the part of the facility staff how satisfied she is, and to convey that as well to the people working in the facility. The fourth solution is something we call Fresh Start Funds. This solution was a small fund that was given to each facility, and the intention was that the staff of that facility could make decisions as to how they thought they could best enhance patient experience within their given context and their facility reality. Here, the intention was to make individual providers and the staff at large feel like agents of change, that they have the ability to make decisions and to try to improve client experience, and to also, as its name suggests, visibly signal a fresh start, a change in the facility by having visible investments that would be a reminder to providers that things are changing, that something is happening in the facility. And the fifth solution is something that we call a reflection workshop. This reflection workshop has a component of contributing to the theory of change as a separate solution, as well as being a channel through which we could introduce providers to the different solutions that I just described. So the way we did these workshops was to conduct the workshop with the clinical mentors of the SM360 project. These mentors then replicated the workshop with each facility. So the facility team was together during these workshops, which we thought was important, given again some of those norms that we identify in the formative research. So in the workshop, there were some empathy building exercises, some reflection around the state of care in the facility, some role play and interaction with the different tools that are described, and the workshop concluded with each provider committing, but visibly committing together with their peers to change patient care for good, to articulate concretely how they sought to do so, and then receive a small pin as a visible reminder of the commitment that they had each taken and that they had taken as a facility. So this was the solution set. And as mentioned, our partner SM60 and the district health office were enthusiastic about this solution set and were interested in testing it in a small scale pilot, which is what I will describe now. So we did have some limitations in terms of the timeline that we had, the available budget, et cetera, which very much informed the evaluation design. We decided to run a quasi-experimental evaluation that was conducted in 10 facilities in peri-urban and rural areas, 5 intervention sites, 5 comparison sites. They were not randomly assigned, but we did try to match the intervention and comparison sites on a different characteristics, such as the catchment area, the facility size, the socioeconomic level of the average patient in that facility, as well as other criteria. All 10 of these facilities were facilities where the clinical mentors of SM360 were working, and implementation occurred from September to December of last year, so a very short implementation period. We sought to measure the differences in outcomes between those two groups, and we controlled for certain variables at endline, particularly because those facilities had not been randomly assigned. Again, given some of the limitations of the evaluation design, we also conducted additional sensitivity analyses to validate some of the findings. For simplicity of the presentation itself, I'll just be providing key takeaways using our primary analytical technique, which is just the regression results, but our more detailed research brief, which is going to be released sometime probably this week, you'll find a lot more detail around the different analytical techniques, as well as more specificity in some of the findings. So this is the theory of change of our intervention, which very much comes out of the formative research that we did. I'm not going to go into all of these buckets, but I'll just highlight a couple of key things, since this theory of change is critical to understand the different areas that we sought to evaluate. You can see that our final outcomes of interest are improved quality of care to clients and greater client satisfaction. And the way that we sought to do that was by the buckets that you can see in light blue. So more regular provision of pain management, a change in provider perceptions around the acceptability of yelling and scolding, for instance, greater empathy and trust between provider and patient, and a few other categories which are mentioned here. And then at the top, you'll see in dark blue some of the higher level mechanisms, the behavioral mechanisms, which we sought to modify with the interventions themselves, which would lead to these intermediary changes. So just to take one example, we believe that in order to increase the regularity of pain management, a provider would need to be familiar with a wider range of pain management techniques, since we found in the formative research that they had a very limited choice set of techniques that they could employ. We wanted to create a perception that pain management was a key function of a provider's role, which in the formative research we had found was not at all the case. And we thought that patients themselves could also be a cue, a trigger for increasing pain management if clients asked for pain management support as well. So it's just an example of some of the higher level areas that we sought to address as a means to generate our final outcomes. One final point maybe to make on this slide of the theory of change is that you'll see a lot of focus in the intermediary buckets on providers. The reason for this is that we're seeking to generate a change in the behavior of providers for the good of patients. So clearly the outcomes are related to clients because the reason for this change is to increase the quality and improve the experience of care, but we don't believe that the onus of generating that change in providers is on the clients. So most of these buckets that you'll see are provider oriented, since our intervention sought to change what providers were doing to enhance client experience rather than put that onus solely on clients. So in terms of the data collection methodology, we did baseline and data collection with both providers and clients. We used quantitative surveys, but we also did some qualitative work as well. We also interviewed the supervisors in those facilities and conducted a few monitoring visits, which were primarily oriented around implementation-esque outcomes. So results. So here I'm just going to share 5 broad takeaways. And again, we have a lot more detail and richness in the results brief, which will be coming out soon, but hopefully this will give you a teaser of what we found in the evaluation. So one high-level takeaway is that we saw that pain management support did improve. And the way to look at this, we have a couple of slides. For one, as articulated in the theory of change, the idea was that if clients were more frequently requesting pain management, we thought that we would see an increase in the provision of pain management. And we did find that clients at intervention facilities were 33 percentage points more likely to request pain management support. Next, we also saw that in the intervention sites, that providers were almost 30 percentage points more likely to rate pain management as one of the most important tasks during delivery. So if you can remember, again, the theory of change, the idea was that if providers had placed elevated importance on pain management among their competing priorities, we also thought that we would see a change in pain management support as well. Finally, we also saw a shift from baseline to endline in the kinds of techniques which were described. In baseline, we saw a lot of ambiguously described techniques, such as chat with the patient or encourage the patient, which are certainly important, but don't necessarily signify that necessarily an explicit task rather than just conversational in the course of labor. What we did see between baseline and end was a shift to an increase in techniques like massage or changing body position or breathing techniques, a lot more specificity in how the techniques were described in a way that very much lined up with the toolkit. A second key takeaway is that we did see that providers were more likely to be emphatic towards clients and believe that clients are cooperative. So as I mentioned, in the formative work, we saw that providers oftentimes perceived that clients were uncooperative and oftentimes attributed this lack of cooperation to something inherently flawed about the client rather than the pain that she was experiencing, for instance. So what we had sought to do with the interventions, with several of them, was to very much generate empathy towards how a client might be behaving and why she might be behaving in the way that she does. There's not necessarily anything inherently wrong with her, but she's just experiencing a lot of pain. And just to show a couple of the statistics around this, so the way in which we saw these changes was we had asked providers to rate on a scale of 1 to 5, whether when giving birth, the clients were often cooperative, and you can see that we saw a significant increase in the intervention sites around that perception of clients being cooperative. And we employed an empathy scale index, and we also saw an increase between the intervention and comparison sites of perceived empathy towards clients. A third key takeaway, and certainly a very important one given that this was one of our final outcomes of interest, was that clients were less likely to report instances of disrespect in our intervention facilities. So the difference was 15 percentage points less likely compared to the clients that were at comparison facilities. for those who are interested in the kinds of disrespect and abuse which were reported at baseline. For instance, clients shared lack of privacy, threats, being left alone, being made to feel uncomfortable. Interestingly enough, we did not have instances of being yelled at or scolded at, which was a bit surprising given that prevalent studies around the world oftentimes point to yelling and scolding as one of the most common kinds of disrespect and abuse. We had seen the same in our formative work and in some of the qualitative questions that were included in this evaluation endline. We also saw evidence of that. So we would imagine that there's some underreporting of instances of disrespect and abuse in our pilot evaluation. A fourth key takeaway was that perceived agency among providers to improve the quality of care was extremely high at baseline. And one of our solutions had intended to boost perceived agency as a means to drive change. And what we saw was that there wasn't an increase during the implementation period. And it's likely that this was due to the fact that providers already at baseline had a high level of perceived agency. So here we can unpack a couple of other elements which are interesting and are certainly things that we're thinking about in subsequent next steps in this work. You know, for one hand, we saw that providers almost universally said that they were interested or very interested in improving care in their facilities. Yet when providers were asked to actually evaluate the state of care of their facility, those evaluations were also very favorable. So from those different data points, we could intuit that there's certainly a general desire to improve, but not necessarily a strongly felt need for improvement, or at least not a strongly felt reported need for improvement, which may also suggest why providers also felt very able to improve client experience if they thought their facilities were already doing quite well. Because the perceived changes that would need to be enacted were probably not very, very strong. And then a final takeaway there's a lot of richness to this data as well, is related to client expectations and satisfaction. In our solution set, we had hoped that we would be elevating the expectations that clients had for care, and that would be one of the levers to improve quality of care and then lead to greater levels of client satisfaction as well. What we saw was that clients had extremely high levels of reported satisfaction at baseline, while also having very low expectations for care. And we did not see an increase in satisfaction over the implementation period, nor did we see that their expectations elevated over the implementation period. Here, there's a lot to dive into as well. We could think about expectations. We asked a series of different questions. For instance, we asked whether or not clients expected that a provider would yell or scold, and found that almost half of clients, for instance, at baseline, and this didn't dramatically change, almost half of clients at baseline did expect that a provider would yell or scold, while at the same time, those same clients almost universally said that they expected good care. So one could guess from looking at these two data points that perhaps it doesn't bother patients that clients yell or scold, and that they're expecting good care while also expecting to be yelled or scolded at, because this isn't something that they find unacceptable. But we also ask questions around acceptability of this behavior, and clients almost universally did not think that it was acceptable to be yelled at or scolded. So rather than coming to the conclusion that clients don't mind this kind of behavior, this data, in addition to some of the qualitative questions that we asked, would certainly suggest that when clients are asked to describe good care or perhaps describe trust in a provider, they, as providers do as well, are very much thinking about this from the perspective of having a favorable clinical outcome. So even if they don't want to be yelled at, as long as their baby survives and they survive, it's a good experience. So the expectations are low in terms of expecting disrespect and abuse, while at the same time reporting high expectations of good care in general. and the satisfaction is very much tied to the secondary expectation of generally good care. So I believe that there's a lot more that could be done here around trying to understand in more clear terms what clients want and how to better capture that as the means for assessing expectations and satisfaction, rather than satisfaction in this current format, which only tells us about the low expectations that clients have in many cases. So just to highlight a couple of quick implementation learnings, we did find that the solution was easy for providers to implement and pretty seamlessly was integrated in existing service provision processes. We very much believe that this was the case because we co-created the solutions together with the providers. We tested and refined the solutions in their workplaces. They did role play. In some cases, they did actual use of the solutions while we were still in the design process. So it wasn't surprising that these did indeed get integrated very easily. But again, something to call out as an advantage of this kind of approach. A couple of other learnings from an implementation perspective. We did see in some of the feedback that we received that several of the solutions did seem to reinforce each other and contribute jointly to some of the positive results. And we heard these comments from supervisors, from the providers themselves, as well as the actual quantitative data. Another piece to highlight with the solutions is that the pain management toolkit in particular was noted by service providers and clients. There were instances of providers talking about how they believed that it had improved their interaction with patients, the way they cared for patients, and clients talking specifically about the massage ball and the kind of support that they received, having this be something that was new. Also of interest is how the Fresh Start funds were used. We did capture what each facility ended up deciding to do with the money. And it's interesting to see the kinds of decisions that each facility made. You see some instances here of facilities which did indeed invest in areas which we would consider to be enhancements to patient experience, additional mattresses so that women could be comfortable in the waiting shelters or in the PNC ward, privacy curtains and paint to certainly provide a more private experience and enhance the physical space. Radio and television, which were placed in the waiting rooms where women were either after giving birth or beforehand. But we also did see some instances in which facilities decided to buy things which were quite clinical and in some cases a little basic in nature, such as restocking oxytocin because they had been stocked out, or very clinical in terms of purchasing small equipment. Again, reinforcing this idea that for providers, for many providers, good care is much still from the lens of clinical care alone. So this quote here is of one of the supervisors in one of the intervention facilities, describing a little bit what I highlighted previously around the interconnectedness of the different solutions, how the promise, for instance, was helpful for setting expectations, and then the feedback box, for instance, would provide an avenue through which clients could then report whether or not they felt that the promise had indeed been held. So again, just highlighting the importance of the multi-prong approach. In terms of next steps, and I'm almost wrapping up, we do believe that some of these early results suggest that these solutions have promise for improving quality of care for women. Our experience would also suggest that these solutions could very much be adapted to other contexts where providers may be facing similar barriers to providing RMC. The small scale nature of this test and some of the limitations in terms of a very short implementation period, and the promise that we found in some of the results certainly makes a case for additional implementation and follow-on research to more rigorously test impact and to also develop a deeper understanding of the effectiveness of these different solutions to ultimately inform programming. In terms of next steps, as I mentioned, we've worked on an evaluation research brief, which we will be sending out together with the slides from this presentation and a recording of the webinar just to make it easy for you all to access. Evaluation research brief has a lot more detail beyond what I was able to cover today. We're also working together with Dr. Kamanga to conduct different local dissemination events and means of sharing results with the district, as well as the Ministry of Health in Lusaka. We're excited to be utilizing these findings in Liberia through our sister project Breakthrough Action to try to adapt these solutions to the Liberian context. And we're certainly exploring other opportunities to collaborate with implementing partners or host country governments who are either interested in the insights or the solutions themselves, and maybe other means to expand the impact of this work. So that is what I have. Can open it up to Ali for facilitating questions.
Thanks, Jana, and thanks to everyone who's already sent in questions. Just as a reminder, you can continue to share those in the chat box and we'll go through them as they come in. So a few that we've already received. The first around the provider-client promise. The question being, when during the pregnancy is the provider promise executed? It is signed earlier during A&C, closer to delivery date, or on the day of delivery. And that first question was answered in the chat box. So it was, as Jenna mentioned, executed at the client's arrival and admission. But the follow-up question was, why was that moment selected?
Yep. So for a few reasons, and probably also worth mentioning that providers that conduct A&C were very rarely the same providers that were attending the actual deliveries, which was in great part why we wanted to look at the actual moment of admission to the labor ward for delivery, since otherwise it could be a promise enacted by somebody who wouldn't ultimately be attending the delivery. But the promise was shared with A&C providers so that they could begin to familiarize women with the promise. And in Zambia, they have SMAGs, which are CHW specialized in maternal health, and the SMAGs were also introduced to the promise so that they could also talk to women more informally about the promise, so that it wouldn't come as a surprise when they arrive to the labor ward. But the belief was very much that the provider who would be attending the delivery would need to be the one that would commit to the patient, rather than have it be very removed from the delivery experience. And actually, in the testing that we did with providers, we added an additional signature at the bottom because providers said, you know, naturally we change turns sometimes, another provider comes on shift, and it's important for that provider who's going to be taking over the delivery to reaffirm the process and to reaffirm the promise that they're making to clients. So there was a second signature section. So that was really the reason for including it there. Certainly there were outlier cases when a woman would arrive too dilated and they weren't able to apply the promise, but in general, women were arriving to facilities at a point in their dilation that the provider was able to do the promise with them upon admission.
Great. We had a few questions around the Fresh Start funds. The first was, what was the process for deciding how and when Fresh Start funds were used? And what, if any, parameters were set on how to use the funds? Did providers and clients need to agree on how the funds were to be spent, or was it up to the providers to decide?
Yeah, so we left this quite open-ended on purpose for each facility to somewhat devise its own process for how they wanted to decide. In the implementation monitoring, we did capture some details on, you know, trying to make sure that our intention was certainly not that the supervisor would decide for the facility, and in the monitoring data, it did not seem like that was the case. It did seem like it was something providers discussed. We did not explicitly say that they needed to co-design it with clients. Again, we just left it very general. I would imagine that there are potentially facilities that did talk to clients, but we did not facilitate the process and oversee it and try to push it in any given direction. More than anything, we just wanted to document what would happen on its own. So I don't remember seeing anything about, you know, providers more explicitly engaging patients in those decisions. It's also worth mentioning that it was not it's a small fund of money, so it was not a very, very large investment that would have certainly necessitated more oversight and a more structured process.
Great, and you may have just answered the next question, but whether the Fresh Start funds could be misunderstood by clients as payment to health facilities or health provider, especially in free health facility settings.
Yeah, so
perhaps
those are very
Jonathan just
small
answered that
funds.
question.
Yeah.
Okay. The next, I believe, came in around the result around empathy. The question was, how did you ensure that the response by the providers at the intervention facilities were not as a result of the Hawthorne effect, or essentially that providers did not alter their behavior because they knew they were being observed?
Do you want to take that, Allie, or do you want me to take it?
If you can grab it, I'm going to collect the rest of the questions while you do that.
Sure, sounds good. So it was a self-reported measure. So there was no observation of the provider for discerning that that empathy measure was very much self-reported data. But I think on that one, given that, there was not a strong focus in empathy in all of the solutions, that was primarily explicitly stated in the actual empathy exercises during the reflection workshop, which was, right after baseline. More of the empathy was intended to be subconsciously built through stimulating caring behavior by management provision in a way that would humanize the relationship, but not in a way that would be priming the provider to be thinking that its intention was to build empathy. So I would not think that there would be any more of an effect in the intervention sites to try to over-report felt empathy than in the control sites. I would imagine that the pressure to try to conform would have been equal in both.
Yeah, I'd also add that we included a few different measures for empathy to perhaps kind of get at that in a few different ways. Okay, so the next question, in my own experience, presence of the partner, usually husband, or another family member at the birth increased the provider behavior. Was this explored in this study?
Yeah, so we explored the angle of trying to increase the ability of birth companions. It was clear in the facilities that we were visiting that that was not policy, and that given the timeline that we had and the kind of focus that the intervention had, we were not going to be in a position to be trying to change that policy as a means to try to increase birth companions, which isn't to say that others couldn't. We were trying to modify what was modifiable within the context and the timeline. I would imagine that that would certainly be the case as well. The fact that providers did not want them there would certainly, the dynamic that we saw in Zambia, at least, and Dr. Kamanga, feel free to chime in as well if you'd like, is that, in most facilities, the birth companions were waiting outside the facility, or in the case that they had a waiting area, were there. The provider certainly would say that there wasn't enough space within the actual labor ward for somebody to be, and that if it was a man, they didn't necessarily have the privacy to allow the man to be with his wife and not be seeing other women in the process. And they would selectively bring in family members, particularly when a client wasn't following instructions and they felt like the family member would have a better connection and more rapport and more able to talk to her about the situation, but then request that that family member depart again. So I would certainly imagine that there would be a positive impact on provider behavior should that have been allowed, but unfortunately that wasn't something that we could tackle within the confines of the project.
The next question is, it would be interesting to see if facility deliveries increased as a result of the intervention. Will this be monitored? Also, were birth outcomes used as a measure, such as mother and neonatal outcomes? Say briefly, that certainly was of interest to the project, but just given the short time frame for implementation of just less than 3 months, it wasn't something that we were able to see any observable differences in such a short time period. Though, as Jana mentioned earlier in calls for larger research, is to understand whether or not this does have any changes in terms of care-seeking behavior, which also fits into the theory of change as well. Jana, I don't know if you have anything else to add to that question.
No, I think you covered it well.
Great. Next, maybe suited for Jana or Dr. Kamanga. Is there a plan to roll out a curriculum to the SMACs to sensitize their communities on this?
Yeah, Dr. Kamanga, I don't know if you're online and able to speak. You would probably be in a better position than I am.
Well, let's see if we can get Dr. Kamanga. I'm going to go on to the next question. We can return if we're able. Oh, there we go. Amek? All right, we'll work on that. Let me get to the next question, and Dr. Kamanga, please chime in if you're able to work through some of the connectivity issues. The next question was the WHO recommendation around perinatal opioids are recommended options for healthy pregnant women requesting pain relief during labor, depending on a woman's preference considered.
So in this setting and in the kinds of clinics that we were working in, that was not typically an option. And again, what we sought to do with the pain management support was limited to emotional support, exercises, non-medicinal sorts of pain management. Again, given our limitations.
Great, let's see if we can get Dr. Amek again. Otherwise, we can certainly get back to that question and respond after the webinar. Oh, there we go. Looks like you're unmuted now, Dr. Kamanga.
You can hear me now?
Yes, we can hear you. Great.
Okay, so I was trying to unmute but couldn't. Yeah, so I think the question was around if this is going to be rolled out for SMACs to be trained. So I think that is one of the way forwards that we can take from these. And I think for me that also links maybe to the earlier question about whether the issue of the provider-client promise is administered at ANC. So I think if women can start learning about it from antenatal care, that they would be asked to sign that client-provider promise, they will be more aware of it and probably also demand for it when they arrive at the labor ward. So that would be a process, and I'm hoping that with the local dissemination that we're going to have, that can be something that Ministry of Health can look at and take up.
Great. Another question. As I'm assuming some, if not many, of the providers were mothers themselves, was there any self-reflection on their birth experiences that influenced their approach to providing support during labor and delivery?
Yes, so this is definitely something that we saw in the formative work in terms of for thinking about contextual cues, which are shaping a perception that pain is inevitable and that there isn't much that can be done. Among them was the fact that providers themselves had given birth and shared their birth experiences, that they themselves had been in that situation and that birth is just painful, and that, you know, they had attended many births that were painful. And, you know, in this context specifically, many providers also remarked that the Bible says that birth is meant to be painful, as a kind of myriad of contextual cues to reinforce that belief. So while we certainly can't rewind back and change a provider's individual experience, in the empathy building workshop and when we were going through the scenarios of pain management, we very much tried to connect it in some cases to an individual provider's experience in addition to enacting scenarios of somebody else, again, to try to connect those dots.
Okay, as you prepare to adapt the solutions to Liberia, I'm wondering if you might consider any aspects of the solutions more context specific, either due to the structure of the health system, cultural beliefs, provider norms. Any thoughts about how well these solutions might transfer to Liberia, and or suggestions for areas where additional formative research is needed?
Yeah, that's a great question. I think we're still in the process of trying to work through what that adaptation process should look like, assuming that many of these may very well be contextually specific. I think the pain management piece is certainly something that I wouldn't necessarily anticipate that would be different in Liberia, but may certainly be different in other contexts where more medicinal forms of pain management are employed. I think the number of providers in a given facility. So in the context of Zambia, there were certainly facilities where a provider was alone, but most providers at least had a supervisor. They weren't necessarily sole providers in the facility. And I think certainly there is a different dynamic in terms of acceptance of yelling and those norms set within the facility and facilities which have multiple providers. And that was definitely something in this context that we saw evidence of, that even if providers were told in their formative training to be caring to patients, that once they arrived to the facility for their kind of on-site training, the norms in the facility were quite different, and they were oftentimes told by their peers that it was acceptable to yell or scold a patient. So I think in a setting like Liberia, we very may well find that that normative piece is not there, that there are more providers that are working alone, potentially. I haven't yet worked in Liberia, and it's something that we'll be working closely with our partners on. But I think if that normative piece isn't there, there may be different levers to pull, and it may be less difficult to try to shape some of the provider behaviors since there aren't those constant reinforcements from others. Trying to think what else might be different. I think we're planning on going through a full user testing phase of, the proposed adapted solutions, and I'm sure that we will find a lot of additional surprises there. I think an area where, at least having done some recent work in maternal health on Madagascar, where I saw a lot of differences were around the kinds of instances of disrespect and abuse that exist in different settings. So certainly existing in all settings in one way or another, but the content of the solutions, the kinds of things that are articulated in the promise or what we want to elevate to get feedback on in the feedback box may be different. Madagascar, for instance, the issue of birth companions was not an issue in the same way that it was in Zambia. So thinking differently about what you focus on given the kinds of instances of disrespect and abuse that might exist, and the kinds of levers that you might be able to leverage, either family or lack of peers in those other settings. So a slightly long-winded answer, but we're excited to try to dive in and see what we need to adapt.
Great. And so, okay. There are no other questions. Just as a reminder, we'll be sharing the slide deck along with a link to the research brief with more findings, as Jana mentioned, in the upcoming days. And so thank you very much for your participation and your thoughtful questions, and have a good rest of your day.
Many thanks to all that participated in this webinar, and Dr. Kamanga, Jana, and Allison for all of your contributions. We are looking forward to next steps of this important work. So thanks very much. Take care.
Thank you.